It's really good to be back together for our monthly social medicine rounds. I'm super excited about rounds today. We always have amazing people, but these folks are especially amazing. And I'm going to tell you a bit more about them. But first, for those who are joining us for the first time, I did want to share a little bit about what our rounds are and why we hold them, and a little bit more, just so you can have a sense of kind of what brings us to this space. So for our January social medicine rounds, just as a reminder, social medicine rounds are really an opportunity for us to get together with those in our community, and not just residents, not just trainees, not just the usual folks that we, talk to, faculty and staff within Monty, but really with our community members. And so we get very excited to be in this space with folks in the Bronx community to talk about issues that impact us, from medical to economic to psychosocial. So welcome to the space. If you're interested in our previous rounds, please take a look at the QR code up there. That'll get you to our previous rounds. You can check that out. I'm going to turn it over to Aquia to please introduce our speakers, and the way that I'll tell you more on the back end of that. All right, Aquia.
Hi, good afternoon. It is my honor to introduce our speakers. So our first speaker is Dr. Lakshmi Ganapathi. She is a clinician investigator in the Division of Infectious Disease at Boston Children's Hospital. She received her medical degree from the National University of Singapore. She's the medical officer in Pediatrics at KK Women's and Children's Hospital and the National University Hospital in Singapore for several years, while she simultaneously was involved in global HIV research and advocacy initiatives with various non-governmental organizations in South and Southeast Asia. Dr. Ganapathi subsequently completed a general pediatrics residency at Boston Combined Residency Program, followed by infectious diseases fellowship at Boston Children's Hospital, working with co-investigators at the nonprofit YR Gatorade Center for AIDS Research and Education, Johns Hopkins School of Medicine, and Bloomberg School. Her current research is focused on understanding barriers to healthcare and HIV and hepatitis C prevention and treatment among adolescents and young adults in vulnerable populations in India. During COVID-19, she's been closely involved in advising families for COVID safety and advocacy and parent, which is a parent collective in Boston. So welcome, Dr. Ganapathi. Sorry about butchering your name a little bit there. Our second speaker is Dr. Julia Raifman. She conducts research on how health and social policy shape population health and health disparities. She created and leads the COVID-19 US state policy database, which tracks more than 200 state policies to prevent COVID-19 and reduce economic hardship during the pandemic. Her research on unemployment insurance and food insecurity helped inform the American Rescue Plan, and she is a collaborator on a study indicating that lifting state eviction freezes was associated with increased COVID-19 cases and deaths. This was a finding that helped uphold a federal eviction moratorium until the fall of 2021. She has also documented how structural racism shaped disparities in susceptibility to severe illness due to COVID-19. She has communicated about policy evidence and health disparities in the New York Times, Washington Post, The Atlantic, BBC News, and many other publications. She has written extensively about reducing disparities in access to vaccines, rapid tests, and high-quality masks, and about data-driven mask policies as a potential long-term strategy to reduce the pandemic's disruptions to lives, health, and the economy. Dr. Raifman is committed to supporting structural changes to improve diversity, equity, inclusion, and justice in academia. Welcome, both of you.
Thank you so much, Aquia. We wanted the longer bios because we wanted you guys to get a sense of just how incredible our speakers are, how many credentials they come with, because that is part of the story that we'll be telling about the world that we find ourselves in now, where healthcare and health-focused communications really does lead to a certain degree of vitriol and attacks. And these two individuals, I think, have done a tremendous job really withstanding that. And we wanted them to share their story in particular, because we are finding that as we're moving forward, folks are getting more and more nervous about speaking up. And what does that mean when we think about information sharing, particularly for historically marginalized communities? So I'm going to turn it over to Dr. Raifman first, and we'll have presentations from both, and then we'll do our usual chatting in our discussion. Feel free to drop questions you may have in real time within the chat, as well as, when we get to that portion. Dr. Raifman?
Thank you very much for that wonderful introduction and for the opportunity to be here with you all. This is such an incredible series, and it's a privilege to be a part of it, and especially with our host and co-speaker today. So I'll be talking about how we are part of the evidence and equity ecosystem and the role that we can all play in that. At the beginning of the COVID-19 pandemic, when unemployment was rising and COVID was beginning to spread, we knew that this problem was bigger than any one research team, and that it would be important to have data on the dates that states changed their policies to reduce the spread of COVID-19 and reduce economic hardship. So it started out with my research fellow and I compiling the dates that 10 states changed physical distancing policies and policies to reduce evictions in the early days, and we grew a database to 200 state policies thanks to the help of more than 30 students. We immediately made the data publicly available and free, and it was very much this spirit of coming together and collective action. And I'm going to come back to that at the end, because I think that is so much of what we need to continue and strengthen and organize going forward in the continuing challenges that we face relevant to the pandemic and beyond. So this is just an example of what some of our data looked like. The data set was largely successful. We were able to inform studies that informed the COVID response. So the first study on state mask policies and reduced spread of COVID was based on our data set. We did the studies on unemployment insurance and eviction moratoriums that were able to help inform federal policies. And I really had my head in data. In my manuscripts, I was really focused on the urgent need for a rapid response, as so many others were. We learned a lot, right? This was really good. We learned about a lot of ways to reduce COVID transmission with more or less costs, right? So we learned about, vaccines and mask policies and workplace safety standards and paid sick leave, and free masks and tests, as ways to reduce COVID transmission without a lot of burden relative to, some of the really burdensome approaches like stay-at-home orders or school closures, which were at the complete other end of the spectrum. But then what we saw happen on May 13th, 2021, was that the CDC really ended approaches to reducing COVID transmission. And at that time, 40% of people were fully vaccinated. And we all know that there were huge disparities in vaccination rates, and that those two had been shaped by vaccine priorities. That vaccines had been prioritized for people 65 and older rather than for essential workers as initially planned. And that had shaped who was vaccinated by the time this May 13th change in policy occurred. And so we started to get worried. And leading up to that, I had seen a lot of misinformation in headlines or sort of nonsensical ideas, and I had sort of dismissed them. This idea that that the pandemic was 100% going away with confidence. This idea that we did not need to worry about variants, that we should take off masks to show that vaccines work. And I would say we would not say that about our seatbelts and our in our airbags, and we would not say that about PrEP and condoms, and I would not say that about masks and vaccines. We really had this population level transmission strategy, and we still needed it because just 40% of people were vaccinated. And so I started to communicate But I started to communicate in this context in which we had really lost track of a lot of the facts. So we had learned that COVID spread through the air in crowded indoor settings, that vaccine coverage and equity was key, that we valued essential workers, that COVID was contagious for about 8 to 10 days, and that we were in it together. And we really lost track of this. We heard that COVID doesn't spread in schools, which are a crowded indoor setting, where COVID does spread. We heard that the unvaccinated, no longer did we care about vaccine equity and coverage, but the unvaccinated were deserving of a winter of suffering and death. There was not room in the budget to pay for N95 masks for healthcare workers or other essential workers. Mandatory return to work happened at 5 days, even if the infection lasted longer. And the risk to we heard a lot about like the risk to the vaccinated, the deserving is low, right? Or the risk to healthy people is low from getting COVID, but that leaves out huge portions of the population. At the time, it left out 60% of the population. Now it leaves out 25% of the population that is still not vaccinated. 43% of people who are at high risk of COVID for one reason or another. And so we can't just divide the population or only focus our policies on the subset of people who are not affected. In fact, Ayanna Presley suggests those closest to the pain should be closest to the power, and that we should really center them in our policies. Now, this misinformation and harm to collective action did not come from nowhere. We saw that there had been moneyed investment in lobbying against OSHA, Occupational Health and Safety Administration protections for all workers and especially for healthcare workers. We saw that Koch-backed groups funded opposition to school mask mandates, and they had arms, the same arms that might be supporting a network that wrote a lot of op-eds, might also be funding people to go to a school board meeting or to compile those op-eds into letters to send to the school board members. We saw that half of states rolled back public health powers in the pandemic. And we see that this continues, that there was further lobbying against healthcare standards in workplaces more recently. And we have yet to see an emergency temporary standard. And this had real consequences. The United States has had the highest death rate from COVID of high income countries, and by a lot. This important paper led by Alyssa Belinsky finds that there were about 250,000 more deaths in the United States than other high income countries on average during the Delta and Omicron surges. And we made policy choices. We did not hold 24/7 vaccination clinics like other countries did. We did not work really hard to reach populations that hadn't yet been vaccinated with vaccines and let them know it was urgent because hospitalizations were just flying up. And we did not have federal support for mask policies during this period. And we had just a handful, in the first part of the pandemic, more than 40 states and the District of Columbia had mask policies, and we saw about 10 states bring them back during this period, even though there was this strong evidence base for them. And that was a policy choice. And I thought it was important, I went into public health and equity to impact public health and equity, and 250,000 people dying in months. I had been working on reducing the burden of HIV, which was about 40,000 people a year getting infected, and which received 10% of the NIH budget for that very important work. And here we had that many people dying in a month. And so I thought it was an unprecedented time, and I knew the policy evidence, and I thought it called for speaking up. And so I started to speak up on social media, to share vaccine disparities, to share that people who were not vaccinated were people who might have healthcare access or information issues. And most of all, that they were people, parents died in record numbers during this Delta wave. I've also spent the time since then trying to understand, what happened. How could this happen? And part of the reason I spoke up was because I knew from the work on HIV that we had made mistakes in the past. that we had initially turned away as a country from the HIV epidemic when it first arrived. And Randy Schultz wrote that the bitter truth was that AIDS did not just happen to America, it was allowed to happen by an array of institutions, all of which failed to perform their appropriate tasks to safeguard the public health. And I think we can say that, with the highest death rate of high-income countries, we are here again. And it calls for us to look at what has happened with this pandemic, look at what can still happen with new variants, and look at what that says more broadly about how we need to have a stronger public health system. And this has also happened before in other contexts. It was actually physicians who opposed, physicians have played a role in information and misinformation throughout history. So physicians initially opposed hand washing because that, the suggestion was that they needed to wash their hands before delivering babies. And, they thought that was unnecessary and burdensome. And fortunately, we came around. Doctors smoke Camels. Doctors were involved in marketing tobacco. And this is important history to be aware of and also not to be a part of. And so, what informed my work in speaking up was first principles of public health, being first, being right, and promoting action and cohesion. And really, it's institutions that are supposed to do this. As an individual, you have a lot less power, right? Because you might speak up and then somebody else might say something different. It's like, well, one person said this and another said that. But if an institution with authority speaks up, that makes a big difference. So the idea of being first is actually that you anticipate misinformation. And this was written in 2014 before social media had really taken off in the way it has now. But being first in the age of social media really takes a lot. And so I think we need to modernize and we need to really proactively put out accurate information quickly, being right, correcting oneself if there's a need for correction, and also sharing when we don't know full information, but sharing what we do know, and promoting action and cohesion, giving people something tangible to do. I also say, I thought about, are we supposed to be, to be objective and not take sides in medicine and in academia. I started speaking to the evidence, the public health evidence and the implications for equity. And I think it is important to speak up. In this instance, I actually learned from a student who said to not speak up is to support the status quo. And so, to speak up when there's a need for change is very important. And there's a lot of this throughout history that neutrality helps the oppressor, never the victim, and that silence encourages the tormentor, never the tormented. This is from Elie Wiesel, a Holocaust survivor. And I think something else that comes from the Holocaust is that people follow leaders, right? They will follow leaders to do anything, including very bad things. And each of us can be a leader in our communities to help people do better things, to help people care about each other, about equity, and to help inform them about what they can do that makes a difference. There's also the spirit of this in the HIV work that ultimately helped lead to HIV treatments that help keep people alive today, and that silence equals death, and that we really needed people to speak up about HIV and the need to do better. We can each make a difference. I think something that we've seen as a challenge is this sense of, do you really focus on what's good for your career? Do you focus on on equity? And these things can sometimes counter each other. And I think we have to find balance in supporting our career and the world in which we wish for ourselves and patients to live in our communities, right? And our neighbors and our and people who are different from us, what kind of world do we wish to live in? What kind of world do we wish for kids to grow up in? We need to strengthen institutions. We can each play a role in doing that. The institutions of which we're a part. And that was a lot of what we learned from the pandemic was that our institutions were not strong enough to withstand a lot of these challenges, and we need them to be stronger. We need to have diverse leadership and participatory leadership, especially at the highest levels, on these really key decisions like the mask policy when 40% of people were vaccinated. It's much easier if you stand together. My work is made so much better by doing it alongside Lakshmi and Stella, and so many colleagues who have joined along the way and who contribute as they can at times when they can. And I think it's important for people to take care of themselves. But I also find that one of the most powerful statements someone can make is when you're having conversations about institution strengthening, somebody else in the room just says, I agree that it's important that we care about equity, or I agree that we could strengthen this aspect of the discussion. And so, I think that's a really good place to start. And if you face challenges standing up for evidence and equity, you're in good company. I think sometimes we're told, is it really, will we only be remembered for creating controversy? And I think we have to look to leaders in history and examples in history to say, well, I think that they really contributed something to reshaping the world. And each of us can play a smaller role in doing that. And that it's not just about a linear career path. It's about more than that. And so, I would say that all of them would say that it had costs to stand up for what's right, but also that it made a really important contribution to their community and ultimately to the world. You can also protect yourself against costs. I think certainly having networks of colleagues and collaborators and like-minded people is very helpful for navigating challenging times. I specifically like that now very much, I think, as protections on social media are eroded. Make sure your address is not on the internet when you are speaking up. And so this is just a helpful webpage. Delete Me has a guide for getting your information off of white pages, which just scrapes your address. You might never have added it, but it will have just been scraped from the internet. So make sure your address, your name and your partner's name and your housemates' names are not on there. And I will also say that, while there are challenges with speaking up, there are also opportunities. And if a few years ago, I would never have imagined that I would have the opportunity to write a commentary in the New England Journal of Medicine, or to testify to the U.S. Council on Civil Rights, or other opportunities that I have had during the pandemic. And they were not why I pursued the work that I did, but I'm grateful to have these opportunities and to be able to, to see that it's not, there are ups and downs, and we have to think about both of them. And if you work to shape a better world, other people will notice it, and you can do more and more together. I'll also say that all of this is happening in a broader context in which democracy is under severe threat. These are remarks by Prime Minister Jacinda Ardern at Harvard Commencement, who said that the foundation of a strong democracy includes trust in institutions, expert, and government. And this can be built up over decades, but torn down in mere years. A strong democracy relies on debate and dialogue. And when facts are turned into fiction and fiction turned into fact, you stop debating ideas and you start debating conspiracy. And that's a lot of where we are, but we can also each play a role in that ecosystem. So we see that people are receiving money to speak up against public health and to speak up against equity. And so who will speak up for public health and equity? We can be first, be right, and be actionable, and we can bring people together. And I add to that, be brave, because the world in which you and your patients live in is on the line, and that we're still in it together. And that I appreciate the work that several of you are doing in your community, and that my fellow speakers are doing in communities and in the world. And we're glad to work together on this continued pursuit. Thank you.
Amazing. Thank you so much, Dr. Raifman. There's so much to be said, but I'm going to turn it over to Dr. Ganapathi, and then we'll jump into discussion.
Let me just share my screen. So I'll actually preface this whole talk by saying that I am not a misinformation or disinformation expert by any means. Certainly, I'm not a media expert, but certainly had to think about a lot of it in my own engagement with the public as well as policymakers and the media. So I do not have any disclosures, but I'll give a very brief overline in terms of how I'm going to organize the next 20 minutes. This is about our personal stories. So I'm hoping to provide my personal story, but also provide specific concrete examples of op-eds that I have written and the thought processes that went into it and what was the message I was trying to get out at that point in time, and how did that play out in the public square as well as among policymakers. In that process, I'm hoping I can talk about specific strategies that I used in addressing misinformation and disinformation. And hopefully also, like Julia did, touch on why I speak. And I really want to spend a lot of time reflecting on the challenges because there are many, but I also want to leave on a hopeful note on the solutions. So I put this here because it really is defining. This is actually a newspaper clip from where I grew up, Singapore. The Straits Times is the government-controlled newspaper, and this is from 2003. So prior to now living through the SARS-2 pandemic, I lived through the SARS-1 pandemic, and it is crystal clear in my mind. On March 1st, 2003, I was a medical student in my third year. I had just begun my family medicine rotation. I was in a primary care clinic in the community, and I received a text message that said, "You have to leave now from your rotation, and you cannot return until we tell you to do so." And this was from my medical school. And of course, what transpired over the next a short period of 3 months was nothing short of a disaster. And the rest of the world was immune to this in large part because of highly effective public health interventions that places like Singapore and other countries implemented very rapidly in the face of a novel virus that did not have any vaccines. When I entered the family medicine rotation, I had just finished my cardiology rotation, and I had the very good fortune of working with Dr. Ong Hock Soo, a very talented young resident who had just finished medical school and had begun his internal medicine residency. Within a span of few weeks, the amazing mentor of mine had passed away. And that was really the memory that I brought with me when I saw the first few cases of SARS-2 trickle into New York City and Boston. In 2020. Now, SARS-1 was defining for Singapore and for me because over the next couple of years, I saw everything about how we did things and how we invested in public health change. Despite it being a very short pandemic, it completely changed the lens of public health. It led to major investments in public health. It led to major investments in public health personnel and infrastructure in Singapore. And importantly, it really laid down a playbook for what to do when the next SARS pandemic comes. And that playbook included a rapid mobilization of public health interventions, the only thing that we could rely on to keep people safe and keep mortality low during the SARS-1 pandemic. So I say this to really to provide a context as to the muscle memory I had coming into the SARS-2 pandemic. And yet, for a whole year, all through 2020, I did not speak at all. In fact, the very little speaking I did was at the institutional level, where I wrote panicked emails to colleagues when I saw the first few cases trickling into New York. I wrote to colleagues saying we should all be wearing N95 masks. And that was the really limited speech that I had, because a fundamental question I asked myself then was, well, what do I know about this? Am I truly an expert? Do my lived experiences count? Have I thought about this enough? This is a new novel virus. So for a whole year, I really didn't speak out except in very, very small circles, just sharing my experiences in terms of what we did and what were some of the larger systemic changes that happened and what were some important policies that I thought would need to be implemented in the SARS-2 pandemic. The next time I spoke, and in fact started a Twitter account for the very first time, was during India's Delta wave. And I really spoke out at that point in time out of desperation. Now, all of my work is in India. All of my extended family is also in India. And in April, and by which time really the Delta wave had very much rapidly spread like wildfire across India, we had formed a coalition. The Indian diaspora here in the United States and across the UK had formed a coalition called India COVID SOS, because it was really an SOS situation. Every hour we were receiving phone calls, text messages from people desperately asking for help, be it in terms of funding. We were mobilizing oxygen tanks because people were dying on the streets. Many of us managed our relatives and friends and colleagues over Zoom, desperately trying to find medications and oxygen for them at home. We watched grandparents and relatives die over Zoom. And so at that point in time, I really spoke out of desperation. And it was a very singular message that we needed to put out, because it became very clear as we were mobilizing all of the support in India that for every 500 oxygen tanks that I sent this hour, the very next hour we needed 5,000 oxygen tanks to get to people, because transmission was spreading so widely. And so the only solution at that point in time, in a country where only 2% of 1.4 billion people were vaccinated, was to cut down transmission rapidly. And in order to do so, we really needed to think of what would that public health intervention be. And this was entering a political minefield. And so the very first op-ed that I put out and disseminated widely over Twitter and to policymakers in India was to call for a nationwide lockdown. However, and this was a political minefield for very many reasons. First is in 2020, India had actually been through a really draconian lockdown. It was very effective in preventing transmission at that point in time, but there were huge trade-offs. The lockdown was announced within a day. Migrant workers were stranded. Millions of migrants, hundreds and thousands of migrant workers had to walk home. Many of them died along the way. There were few social safety nets that were invoked. And so the term lockdown itself really evoked a lot of pain for people. And so in really pushing forth this message, we had to break down a couple of central questions. Why lockdowns work at cutting transmission rapidly. So that was the epidemiological question. Why this over interventions, and why now, and why nationwide, and what really are the stakes? And the stakes were that this was a new variant where hundreds and thousands of people were dying. And this was a new variant that was killing within a matter of weeks. And then there was the other central question, the societal question. What are the trade-offs if you're going to propose this public health intervention? And then the policy implementation question, how best to implement this so that the trade-offs are ameliorated? And so putting out this message was really not an easy message, because it wasn't a palatable message. It was not a message that policymakers actually wanted to hear. And so in order to do that, we rapidly convened a multidisciplinary collaboration to arrive at an actionable alternate vision. And what was this vision? This was a vision to do a lockdown, but to do it humanely by rapidly mobilizing social safety policies. In order to do this, we spoke to developmental economists. We spoke to people in the Indian Administrative Service who very anonymously intersected with us, and really devised a very rapid policy, and which included involving the public distribution systems to ensure food insecurity was addressed, and leveraging these systems for cash transfers to really do this as a humane public health intervention. And in communicating this message, we really needed to get to the heart, a very emotional reaction to lockdowns, right? This was a very painful memory for very many Indians. And that involved communicating terminology and using terminology that best reflected an alternate vision. And the vision was we needed to cut transmission, but we needed to do this humanely. And so we recoined lockdowns as humane shelter at home. So this was really one one sort of package of strategies that we used in really breaking down central questions and communicating why this was important, why now, and presenting an alternate policy vision around this. So subsequently, after India's Delta wave, which I will come back to in terms of lessons learned and some of the challenges, I had the opportunity to really sit and think about public health interventions on the population scale. And then I took on the next political minefield, and that involved taking on the concept of mandates. Now, mandates are certainly a very debated aspect of our pandemic response. And this is a piece that actually brought my husband and I together. He's also an infectious diseases physician, and we wrote this together. And this is how I got to know Julia as well, because on Twitter, I had 200 followers then, and Julia was one of the very first few people that I sent this op-ed that I wrote in the Boston Globe to. And I think the principle that I wanted to make is when you are addressing these topics or these interventions that invoke a lot of emotions and vitriol, there needs to be communication beyond the facts. And in this piece, that's what we attempted to do. We explained beyond the facts the public health principles behind interventions such as mandates. And to put it in very, very simple terms, mandates were really about the universal application of an intervention. And then we needed to go beyond explaining the principle to explaining some fundamental concepts. Why universal application, and why does universal application reduce inequitable outcomes? And then again, anchoring all of this was really putting out a message of what are the stakes. The stakes were, as Julia mentioned, we were living in a society that was really under-vaccinated, and we were dealing with a virus that didn't kill in the order of years. This was a virus that in every search was killing in a matter of weeks. And that was really the urgency, and those were the stakes. And so to address the second question as to why a simple principle like mandates that universalizes public health interventions addresses equity, this has really been a central framework for communication. And this has been a framework that I have relied on in every single piece that I write. And that involves naming a few truths at the outset. First is objectively, and we cannot deny this, this has been an unequal pandemic, and this has been an unequal pandemic from the outset. However, to really talk about an unequal pandemic, we have to recognize that the inequitable structures that yield this unequal pandemic are by design, and they precede the pandemic. I think we should also recognize, and this is a truth I'd like to name, is that the pandemic has been experienced in fundamentally different ways. Some groups have had far more privilege in weathering the pandemic in very specific ways. And how we have experienced the pandemic really shapes our lens, but it also shapes our language. It also shapes our rhetoric. What has been a really important point of reflection for me is knowing that the inequitable structures in our society and in our institutions are by design. We always knew that the inequitable outcomes were predictable. And so this cannot be retrospective knowledge for us. And so my communication has really been, in some sense, consistent, and not only during periods of surges, because knowing this means that we need to shape the equitable outcomes prospectively, and this needs to be by design. And we need to call out this design during periods of peace when nobody feels any threat. And so that's exactly what we tried to do. This was a piece that was published right before the Omicron wave. And this is when we called for the universal application of public health interventions using mandates. We used the examples of mask mandates because mask mandates decrease disparities. How? Who uses public transportations? Individuals working essential jobs who were more likely to be under-vaccinated. And therefore, it is an equalizer in terms of where you apply these mask mandates. The second concept where I applied this principle of universal application was in school testing. So when we wrote this piece, when the pandemic began and kids returned to school. By this time, kids were back in school after lockdowns in various states. But the wealthy school districts, which had the funding, were among the first school districts to actually to implement universal testing policies. Now, my son entered elementary school in a Boston public school where 80% of kids rely on free school lunch that very fall, and he was still waiting for school testing to happen. And when school testing was finally implemented, uptake was significantly unequal. And yet there was a very simple way of equalizing uptake such that everybody actually had the access and the opportunity to benefit from testing. And that was to really make testing an opt-out policy rather than an opt-in policy. Again, a concept where you universalize public health interventions to reduce disparities. So this was really a way to communicate beyond the facts, to communicate both the principles as well as the concepts, and tying in both of those to what Julia and others have said have been a characteristic of the pandemic, an unequal pandemic. Now, obviously, as a pediatric infectious diseases physician, but also as a parent, I think a lot about schools and I think a lot about kids. And much of my work during the pandemic has really been around COVID and schools, where I've been very fortunate in my personal capacity to advise at my son's school, but I've also been very fortunate to work with a community collaborative of parents and grandparents called the BPS Families for COVID Safety. And one thing that has become very apparent to me during the pandemic is that communication actually has to extend beyond facts. We often think about disinformation and misinformation as this is just misstated facts, but it's actually not just misstated facts that we're addressing. What we're addressing is narratives, and to address narratives, we really have to get to the crux of narratives. Now, many of you may be aware of a campaign a while back that began probably in February of 2022 called the Urgency of Normal. And really along the theme lines of the pandemic is over, we need to get back to normal, and normal means not having any public health interventions. Now, the Urgency of Normal was a coordinated group of physicians and scientists and parents, and the advocacy really began in schools and what ultimately became much larger advocacy. And it's centered around a few specific pandemic interventions. One was the whole pandemic intervention that included masking kids in schools. And so this group was very intent in pulling back masking. And then there was this huge push to really paint school closures as a failed policy and what I call learning loss. I often put it in quotes because again, and really talking about learning loss in what I would say in very one-dimensional ways. But encountering some of these groups and really some of the information being put out by these groups, we really needed to get beyond the actual specifics of the group's information. And so in a series of tweets as well as op-eds, I really got beyond that and asking a couple of core questions. In this information and these narratives, whose narratives are represented? What data and whose narratives are completely omitted? Whose voices are not represented in these narratives? And then getting to really a fundamental question. What is normal? Who is calling for normal? Who has a seat at the table of decision making? And so the pieces that I crafted and the tweets that I crafted around this time got to these central questions. And it was important for me not just to address whether masking was good or bad for kids, but why is this narrative about masking being perpetuated at this point in time? And so these series of questions offered me a framework to really address these narratives. And so again, I came back to the same framework. addressing the crux of narratives will, in the context of schools, means that we have to talk about the inequities in schools. If you want kids to return to normal, then we need to acknowledge certain objective facts. One, that the toll of COVID has been disproportionately borne, including in children, among Black, Latino, and Indigenous children who have been disproportionately hospitalized. The risk of death in Black, Latino, and Indigenous kids has been at least 3 times that of white kids. And more than 150,000 kids who have lost a primary, among more than 150,000 kids who have lost a primary caregiver, 65% are Black, Latino, and Indigenous. And we can talk about masks, we can talk about learning loss, but really it is a one-sided conversation if we do not acknowledge, or if we choose to ignore, some of the most important consequential lived experiences, which is disability and death. And those are the stakes that are often never mentioned in these narratives. And so I put up this tweet, which I wrote in response to Urgency of Normal, because I'm going to come back to some of the public responses to that. But again, we cannot talk about a normal, or we cannot talk about the pandemic without actually looking at what does our normal look like in pre-pandemic times. And I often give the example of ventilation upgrades, right? When we think about public health interventions, we think about a variety of structural interventions. We think about interventions like improving ventilation in schools as a longer term systemic intervention. However, we have to ask, even before we go into that, are schools without windows normal? We have schools without windows. Can we talk about ventilation upgrades without talking about the fundamentally inequitable system of funding public schools by way of property taxes? Can we talk about ventilation upgrades without talking about redlining? And so the point is that it's more than just about talking about this specific interventions, but really getting to the crux and really questioning narratives and what really is the lens of normal. So then I realized a third thing in communicating and addressing some of these narratives is that it wasn't just important to address narratives themselves, but to address the thinking beyond certain narratives. And this is an essay that was written in January in the middle of Omicron, when there were so many debates around schools closing, and this insistence schools had to be open, even if all the teachers were sick, and we really shouldn't be masking kids. And all of these debates were happening in the background. And my colleague and good friend, Professor Michelle Holmes, wrote a very beautiful piece called The Folly of School Openings as a Zero-Sum Game. And I go to this piece often because in addressing narratives, we have to address a very specific thinking around these narratives, and that is zero-sum thinking, and either-or thinking, and all-or-nothing thinking, and forever-never thinking. And I often see that, and I give very specific examples that you may or may not have seen. For example, there is no point for children to wear masks in school if no one else in the community is. Masks do not work if people aren't wearing them all the time. Remote learning was bad for everyone. And in really addressing these things, I think it was important to put out the message that what was fundamentally wrong was not just the narrative, but the thinking beyond the narrative. That zero-sum thinking, either-or thinking, really does not allow for the possibility of sophisticated thinking around when do we use public health interventions? How do we use public health interventions? Does one size fit all? And an important point also to be named is that either-or thinking maintains the status quo of those already privileged, because it doesn't make room for sophisticated thinking around some of these issues. So sometime right after addressing some of this mounting calls for the urgency of normal around schools, this really became a larger movement. And as Julia pointed out, really the pandemic has been a rallying cry after every single wave over the last 3 years. And this is a piece that I wrote together with my husband, as well as Professor Michelle Holmes. And this call to really get rid of all our pandemic interventions happened right after the Omicron wave. This was in February, and at a point where we were still losing 1,000 people every single day, and that number had not budged. 1,000 people were dying every single day for the past 6 months, and these rallying cries started again. The pandemic is over. We need off ramps. We cannot be doing these interventions forever. And in this piece, we address some of the crux of those questions. Whose narratives are represented in this call, in this declaration that we're done with the pandemic? And we made a couple of observations. First, that physicians and public health experts making these calls were holding up wealthy towns, counties like Marin County, Hopkinton, Massachusetts, as examples of how to begin thinking about off-ramps. And these were the counties and places in the country which had the very first access to all of the public health tools, including vaccinations. And this was at a time when vaccine disparities were still stark and treatment disparities were still stark. And really, this perception and the perpetuation of a narrative that everybody has the tools now to protect themselves. And so we had to talk about whose narratives were represented when they say, when groups like these say everyone has the true tools now. And then the question of whose voices are not represented in these narratives. And so we made the observation that there's a glaring omission to these calls, and they're generally not being made by Black, Latino, and Indigenous experts in medicine or public health. And so a central question I've often asked myself, and I don't have a good answer to this, is has the media given these experts in communities that have disproportionately borne a toll of the pandemic equal, if not greater space for their voices? And then I come back over and over again to what is normal. Can we talk about normal without talking about inequities that long precede the pandemic? And can we say normal with a straight face when significant inequities in access and outcomes persist? And what do these narratives ultimately represent? And again, this was something that needed to be named, and I will say this in no uncertain terms, the COVID-19 pandemic is a racial justice issue. And these calls for normal in January really began strikingly a year after our country supposedly experienced a racial reckoning. And what do they represent? A disturbing lack of true solidarity, really shaped by an epidemiological, racial, as well as moral blind spot. And so these are a set of sort of very short snippets that I've hopefully brought you through my thinking around these pieces and sort of what I needed to get beyond, and not just the facts, but to really get to crux of certain narratives. But here were some of the challenges that I encountered. One is that thoughtful information and addressing fundamental narratives, it's incredibly hard to craft. And it takes a really long time to write. Our very first piece on India's shelter-at-home policies that we proposed involved getting a whole collaboration of people to think about it. Whereas really pitching this and getting it out there into the media in a cycle that moves on to the next hook is in fact very challenging, because thoughtful pieces take a long time to write. By the time you pitch it to 10 different people, the media has moved on to the next thing that they're looking for somebody to write about or talk about. But because good information, high quality information is so much more thoughtful and harder to craft, misinformation and disinformation actually travels a lot faster, because not much thought actually needs to be put into misinformation or disinformation. A key strategy in terms of how misinformation and disinformation works is that it works by repeating the same thing in multiple venues, either by the same person or different individuals. The reason the urgency of a normal campaign was so effective was two reasons. One is, I think, policymakers aligned with that vision, but also there was a collaborative that really pushed that narrative across multiple different venues. And which brings to a solution, which is how do you counter some of these coordinated efforts? The other thing is that, as Julia says, ultimately the responsibility for thoughtful, high quality information lies at the feet of institutions. So you as an individual have minimal power, and certainly not the same as having a regular slot or column in a newspaper to write on a weekly basis and to shape the public opinion. That's an enormous amount of power that many of us do not have. And then there's actually a central question. I began this whole journey of communicating, asking myself a central question, like, am I an expert? And I think I've reconciled that over and beyond my initial self-doubt. I've come to realize that the public doesn't know the difference. Policymakers do not know the difference. We often think that experts are those who have an MD or a PhD, but I really think expertise extends beyond credentials. It involves the ability to self-reflect, evaluate one's own biases, fact check oneself. And this is why my pieces take so long to write, because I put it through a fact checking process. I have 10 others to check every single link that I've put in. And really being circumspect about what one does not know. And this is really important, having external comparators. And so I think this is a mental exercise that I go through, but I will say very honestly that doing this mental exercise and taking a step back means that the information that I put out travels a lot slower than misinformation and disinformation. And so I would love to open this up for discussion down the road. And then there's also this very, very real challenge where every public health intervention is what I call both siding the pandemic, right? Every intervention needs to have a for and against. It's not whether, well, we just have to do this because there's evidence for it. It's who are the people for it? Who are the people against it? And so this both siding in the pandemic has been a really challenging sort of a really challenging aspect of it to address. And I'd say this, that when we have an unequal pandemic, when the outcomes have been so unequal, there are no both sides to equity. You're either equitable or you're not equitable. There's no both sides to for or against equity. And so I think those have been some of the challenges I've had to ruminate about. And so I come back to this because I think one of the solutions to countering misinformation, really putting out thoughtful ideas, is you really have to put out that thoughtful ideas in multiple venues. So when we first wrote the piece in Indian media on India needing a nationwide shelter-at-home directive, that was a piece, but we continued to put that out because it is an important piece to think about for the next pandemic, when the next virus comes 50 years down the road or 20 years down the road. And so I had the opportunity to write about this in journals, but I also had the opportunity to really look back and retrospectively reflect. We called for this. Would that have made a difference? And I will tell you that this was one of the hardest papers for me to write because this was a counterfactual model. Had we had humane shelter at home a lot earlier in India, how many lives would we have saved? And the stakes, and in retrospect, these were the stakes. 3 million people died within a span of a few weeks. 3 million. And so, I share this to say that when you have a vision and an idea, you have to find different sources to keep pushing that forward in different ways. And that's how disinformation works, by repeating the same thing. And so we have to put out the quality information in multiple different venues. And so then I'm going to come to this point about how you handle vitriol. And I actually put this, and I asked Stella, is it okay if I share this? And I am going to share this. So right around the time when I talked about the narratives of the urgency of normal and asked these key questions, I received a letter from the Board of Registration of Medicine here in Massachusetts, and I'm going to read it out verbatim. In a series of tweets and op-eds, I had talked about an unequal pandemic, and in my tweets, I had very much presented data on what had been the disproportionate toll of COVID-19 on Black, Latino, and Indigenous children. It also made the point that wealthier districts had far earlier and access to several of the tools, while other school districts really were still waiting for the tools at the time when normal was called. And this was the complaint. Dr. Lakshmi Ganapathi Twitter account had racist remarks she made. I urge the state and children's hospital to see the care that she gives white children, as her racist remarks were aimed at white people. Her remarks were full of hate and intolerance and fear for any person who's white, and seeked care from her, as she made it clear that she dislikes white people. Now, this was certainly jarring for me to receive because I've now been practicing for over 20 years, and this is the very first complaint that I have ever received, actually, in my career. But I had to take a step back because I ultimately realized that this actually, I care less about this. First, because talking about inequity will make people uncomfortable, and there can be no progress without discomfort. So I either take it on or I do not take it on. And the second thing that I worry more about is not the vitriol. In fact, in all of my communication, a question that I've often asked myself is, am I speaking instead of somebody else whose voice should be heard? And this is where working with community groups like FEMCOSA has been really important. And there have been many points where I tell the media, you know, I would like to speak to you, but I think this person would be even better and has a really unique perspective that should get out there. And so I think for me, the vitriol has mattered less because I'm presenting what are objective facts that are publicly verifiable. And what's been more important to me is really ensuring that I'm making space that people's voices need to be heard, should be heard. And then I want to talk a little bit about why do I speak, and we can really talk about this a little bit more in the discussion. Now, we talk a lot about, we've anchored this whole discussion on the pandemic because that's something that's right in front of us. We've all had this collective experience. And I will say, you know, Julia's data has wonderfully informed policies, but very many of the things that I've spoken about or written about or ideas I've communicated about have simply not really created a dent on policies at all. And I'll be the first person to say that. But yet I don't see that necessarily as a disappointment because I speak with the long view. I speak about today's pandemic for the benefit of those who will face tomorrow's pandemic. I had the lens going into SARS-2 because I had that muscle memory from SARS-1. I had colleagues who wrote about SARS-1. I read those articles. I framed my thinking around that because somebody took the time to speak and write about SARS-1. And I hope that today, when I speak, somewhere history will record my dissent, even if policies were ultimately not influenced, that somewhere history will record that there was a group of people, there were these individuals who did not agree. And so that is recorded in history. And I speak, as I said, for the better things that I know I will not live to see. All of us stand on the shoulders of the collective labor of those who spoke out and fought for the things they did not live to see. And we are reaping those benefits. And we bear that responsibility for those who will come after us. So I'll end here and open up the floor. Thank you again for this opportunity.
My goodness, Dr. Ganapathi, Lakshmi, that's like a drop the mic moment, that last slide. I found myself feeling very emotional in these rounds because I think you've both made the case for the urgency of speaking up and how much thought, work, and everything, bravery goes into it. And I just want to say on behalf of all of us that are here, thank you both so much for all of this. Thank you for coming and sharing information, but also for just your ability to be just transparent in the way that you have been. Can everyone hear me okay? Okay, cool. I remain concerned about internet problems because that's the kind of day that I'm having. We have a lot of questions. I know I have a lot of questions. We're going through 5:45 up until maybe even 6 if folks want to stay. So I want to, and I want to thank you guys for giving us this time. I want to go ahead and turn it over to Emily, who has her hand up. Go ahead, Emily.
Hi. First of all, I wanted to say thank you so much for coming. This was a really enlightening conversation for me. I don't think a lot about the idea that people are actively contributing narratives that counter what we hope patients hear. I was wondering how you feel the lessons you've learned could be applied to other things where people either receive disinformation or where there are active misinformation campaigns. For example, I'm really active in climate and health, which is obviously a topic where many people have kind of an active interest in not getting our patients good information. So how you think those lessons could be applied to other issues where patients aren't necessarily having easy access to good information.
I think a lot of those principles of be first, be right, bring people together around what they can do are helpful. And I think I saw actually a really nice article, Share NPR, kind of debunking this headline that, the coffee filters that are disposable are better for the environment, so everybody can relax. And what I really liked about that is they said, like the individualistic behaviors are not going to be, that is not necessarily strong evidence. It's not peer reviewed, but also, keep your eye on the ball. And what we really need is government regulation of the major sources of pollution. And so I think that we have lost track of the big picture and the basic facts so thoroughly with COVID. And I think really proactively putting out that information. And as Lakshmi says, like changing the frame, I think this notion that, if there are disparities with school closures and there are disparities in education, then, we can't do anything. Well, actually, like we have a lot of policy options in the middle there of like how to maximize both, but we're not talking about them. And so, I think just kind of proactively putting out information about what is helpful and also how people can contribute, what they should ask their policymakers to do to help and what's most impactful.
Yeah, I've had to think a lot about where people get their information from, and if you want to disseminate information. But I think Julia also makes a really important point. We often think that information equals change, but often information in itself can breed inequity because not everybody, as you know, it has high quality information. And that's why we need these structural policies, because information alone campaigns, in fact, there are multiple public health case studies in this information alone campaigns, in fact, make inequity worse. And I'll give the example, but we're going to talk about other public health issues. And I brought this up actually in our op-ed about the mandates to give people some parallel examples. If you look at folate supplementation to prevent neural tube defects in babies, in pregnant women, for a long time, we actually didn't have this policy of just folate supplementation, universal folate supplementation. All we did was to give people the information about folate, which meant that some people had access to that information, other people did. And what really did make a difference was a policy of universal folate supplementation. Similar to fluoridation of water, you can tell people fluoride is important for your teeth, but some people are going to take fluoride and other people are not going to take fluoride. The people who can get their hands on fluoride will do it. And some people will get access to good quality information about why dental health is important, which is why fluoridation of water is actually a universalizing, equalizing structural way to equal things for everybody so that everybody benefits equally. So I think giving information is really important. Thinking about where people get information is really important. But I also think this is why the labor needs to be at the policy level as well, and at the structural levels, because that really is where you have the opportunity to equalize, because information, there is a lot of, like I said, information travels a lot slower, disinformation travels a lot faster. So relying on that alone, I think, is challenging. But on the other hand, it can certainly work hand in hand with policies that Julia is mentioning.
That's a really good example, Lakshmi. I remember at the start of the first Omicron wave in December 2021 to January 2022, the patients of mine that came in wearing kind of regular surgical masks, I would tell them, this surge is particularly concerning, you should change to N95 masks. And the response that I would get a lot of times would be one of surprise. Like a lot of people didn't know that. And if they could afford it and could find it, they would go ahead and change their masks. But what you're saying is that information, first of all, is so slim. There's so many reasons why when people get that information, they may not be able to act on it. And then not everyone's getting that information. So the better thing would have been, could we just mail N95s to every household and kind of continue to do that? So I think that there is definitely a way in which we saw those exact examples with folate and others happening with the pandemic as well. One question I did want to ask you guys that, I hear sometimes, and I'm always really interested because a lot of my work is around advocacy. And so I do think that this is something that I feel very passionately about, but not necessarily as part of the job of being of a clinician. And that question is, Like, what are your thoughts about health professionals, kind of across the gamut, and non-health professionals, but people with information, having a requirement or a moral imperative to share key information about health with the public, like around COVID, like around smoking, et cetera, with the public, because we do have some of that insider view? Is it part of our job? Is it not part of our job? How should we be thinking about this? And maybe, Julie, I'll start with you.
Yeah, I think we need to have more conversation too, just about values and how they, the evidence is shaped by a context of values and a social and political context and a highly inequitable social and political context. And so I think especially in that context, when we have the privilege of having an education and having information that can help people, I think speaking to that evidence and speaking to inequities and speaking to policymakers about what's driving inequities, I think is really important. I will also say, like, go meet with your policymakers. Like, when we started meeting with policymakers, they said, well, we'd heard that the hospitals were overloaded, but we had not heard that like policies could help. And so, I think that the people who are lobbying against COVID protections or public health more broadly are meeting with policymakers all the time. And so meeting with policymakers, having kind of three takeaways for a policymaker that they can, that are actionable for them. I think that is the kind of thing that we can all do as well. And just informing them about, what you see in the clinic environments. And I think there's also like this sense that we've all gotten kind of run down, gotten used to like not being able to make change, but there are new administrations in many states. There's been an election. Ahead of the election, it was actually a very challenging political context to change a lot of things. And now there's actually more opportunity to say, hey, we actually still really need that workplace safety standard. And we still need strengthened systems to improve vaccine and booster equity. One key point right now is, it's a policy choice. It's not inevitable that vaccines start to cost a lot of money and treatments start to cost a lot of money and widen already large disparities. And so, I think speaking up about policy choices that we're making and how we should make policy choices that reduce inequities, not exacerbate them.
Yeah, I've thought a lot about this in over and above all of this COVID work. A lot of my work centers around substance use policy. And I too began, my entire sort of medical career working in the HIV pandemic in India. And that's where I continue to be very heavily invested. For the longest time, I actually did not intersect with the media or communicate some of my work in really the lay media. And I'm increasingly realizing how important that is. One is that health is political, and the social determinants of health really are huge contributors. So whatever outcomes that I would like to see in my patients cannot happen independent of the larger labor around policies and intersecting with policymakers, because that shapes health in so many significant ways. So I think if we had a passion for particular outcomes, I almost feel like we cannot divorce that aspect of our works from dealing with that individual patient in front of us, right? Like, what are you going to do for the next 10 patients? Like, are you going to see them go through this over and over and over again? What is the change you would like to see? And so increasingly, I have started to really communicate my scholarship a lot more. So a perfect example is that I do a lot of work among youth in marginalized populations in India, and those under the age of 18 simply cannot get an HIV test or an STI test without parental consent in India. And I see a huge number of youth who really do not have access to treatment because they cannot get tested. And so to really have an impact in that way, I have to influence policies which really shape everything. They are the starting point to every single downward downstream outcomes I'm trying to address. So I almost feel like if you really think about the issues you're dealing with, it's almost a no-brainer to do both.
I agree with that. wanted to also ask around, I think specifically this question for trainees, and I think you both mentioned it. I know, Julia, you've been targeted and doxxed because of your work. Lakshmi, you mentioned, having a complaint sent to the board about your work. And for residents who are, and trainees who are kind of starting off, Emily talked about doing climate change work. What advice would you have for them? And specifically, how can we as an institution and we as faculty and community members support, especially our trainees, as they really kind of work to be more outspoken or continue to work to be outspoken? They're often much more than others about some of these issues.
I think you're already, getting started on that path, but like organizing yourself so that nobody's speaking alone, and you're really speaking as a group. So it makes it much harder, when people are singled out, or speaking alone, it makes it much easier for them to be a target. And so, I think speaking together as a group is helpful. I think being strategic about it, like there's a lot you can do at your level and below in organizing. It's a lot harder to change institutions, looking further up, but also important. And so I think just kind of knowing that hopefully can help you be strategic and go in with several people who can say, yes, I agree, this is important, line up people who can help move forward key objectives. And just like with, with talking about the big picture on climate and the big picture on equity, you really prioritize what is most important to improve, and think about who are key allies who might be more senior who could help along those lines. And I think like the biggest institutional successes have often been people who are more senior, who have resources, who can then allocate to helping to support change. And, it's not without risk, like there are downsides, but like I said, there are also upsides. And, I think I'm fortunate to have privilege and to have the education that I do, to be okay with the salary that I have and not, necessarily needing to rise higher and higher. And so to say, I thought that the most important thing for me to do was to speak up when these deaths were happening and I could see it happening. And now that I have spoken up about the deaths that happened so quickly, I think speaking up about structural change and preparedness to not let this happen again remains important.
Yeah, I think Julia brings up a point. I think there's always strength in numbers. And I think forming the collaborations and a support network as you speak is really very key. It's interesting. I spoke about Singapore, and I relayed this to Stella too when we first met. I spoke about Singapore's SARS response. What is also true is that Singapore is what we call an illiberal democracy, and many people would say is authoritarian in many ways. There are really very few civil liberties, and there's in the entire country maybe one place where you can have nonviolent civil protest, and literally one park in the whole country. And I have been very, very fortunate to have in my orbit very close friends who are independent journalists and activists in Singapore who essentially have been jailed, questioned, and really have had careers destroyed by the government apparatus for really very innocuous activism around substance use policies or death penalty or even just free speech. And so for me, speaking up is really a privilege because I never had a voice for years. And in fact, I only found my voice when I moved here to the US. And so it's a privilege that it's sacred to me to speak up. But again, in doing so, I think there are multiple ways, as Julia said, being strategic, having a mental exercise. Who is my audience? What am I communicating? Is this the medium where I want to put this message out? I think having a couple of thoughtful questions and frameworks around speaking out can also be a way to protect oneself.
Super well said. I want to turn it over to Louisa, who shared a couple of sources in the chat that she's also written, just from a little bit of a different non-clinical, non-public health perspective. Louisa?
Hi, everyone. So I wasn't expecting to speak, but thank you for asking me to. Estella. So I know Stella and Lakshmi and Julia via social media, and we interact often because I'm also very passionate about these issues, but I'm actually in the humanities. And I'm also the parent of a third grader. So I come kind of from that angle. I'm professor at Spanish at a small university in Philly. And so my first op-ed that was published in Esquire that I posted was inspired by those narratives that Lakshmi was talking about. So I've been coming at it from the narrative angle, which is one of my areas of expertise, being in literature and culture. And one of those op-eds that was aimed at university people, that was talking about universities are fine now and masks off and all that, from somebody at a very elite university where we know they have the best resources. And I'm in a building at a small university with, like Lakshmi talked about, windows that don't open, right, and et cetera. And I'm seeing the same voices being centered, right, of people at quote elite universities. We all see the op-eds all the time from the same people. So I decided to tackle that piece about how the media was being complicit in some of those perpetuating these narratives that Lakshmi talked a lot about, because they keep centering the same voices, right, of those people that have all the best resources and aren't impacted the same way as many of us are. Because I'm also in Philadelphia, my child is in public school, and this is a city that they're still trying to get asbestos out of some of the school buildings. They've had problems with lead, windows don't open, had to close schools because it got too hot and they don't have enough air conditioning, right? So I've been dealing with all these inequities, for a long time. So to hear people with these flippant attitudes about everything's fine and just go maskless was really it bothered me a lot as a parent, but just as somebody that deals with inequities a lot, as some of you know, because I deal a lot with race and inequities and stuff in my professional work. So then I did a thread on Twitter pushing back on the urgency of normal and all these people with these narratives about school and learning loss, because again, I felt learning loss was basically a made up thing that people were weaponizing to justify schools opening without mitigation. And that thread got very popular. People were asking me to turn it into a piece. So I turned it into an article on Substack. So that's kind of the background. But I follow you all, learn a lot from you. And I try and bring, like I said, that lens to help the cause of trying to get equity and mitigations and resources for people.
Thank you,
Thanks.
Louisa. I appreciate your perspectives, because I think it's what one of our speakers said. I can't remember who said, you may not feel like an expert, and yet your perspective is one that needs to be shared. I think that was Lakshmi. And I think it's important because there's so much that each of us has to offer. Louisa, your comments also make me think about the importance of speaking from your lived experience, and how a lot of times that perspective may not be a part of the conversation. And I hope that that's a note that we can all kind of keep in mind as we start to wrap. I'm going to go over to Julia and Lakshmi for final thoughts as we bring our session to a close. Julia, you're on mute.
Thank you. I was just going to build on that point and say, I think academics who are disproportionately white and disproportionately high income, high education, have been really overrepresented in the media. And we're there to speak as experts, but a lot of times people are speaking based on their personal experience, and their personal experience is valid. They may know their child's school's data inside and out and have learned a lot from that, and that's valid. And their 95% vaccinated school is very different than most schools in the country. And when we speak to media, we're really speaking to policymakers across the country and to the public across the country. And so, I do think that that expertise from lived experience is valuable, that academics also play a role, as Lakshmi was saying, in helping to support better representation in media. If we are given the privilege of working with media, then that is a really important aspect of the work that we can do. It's just really nice to come together with this group. Thank you for taking the time to be here. Thank you for excellent, really thoughtful questions, and thank you for being interested in learning about this topic. And I hope it was helpful. And please be in touch if it's helpful down the line.
Thank you, Julia.
And I would say the same as well. I am sort of the worst public speaker and also extremely media shy. But I think one thing I realized is there are lots of people who actually do not think, who speak and have no comps doing that. And there are lots of people who really do think they're experts. And really all of us who are questioning ourselves are probably the people who should be speaking out there, because I think we're capable of actually putting out far more thoughtful content. And every time I ask myself and self-doubt myself, I just have to look at the next person who's literally saying the first thing that comes to their mind. and so I think if anything, I hope my experiences and the pieces that I've put out serves as an encouragement for others who, like me, question and ask whether it is my place to speak. If you're questioning yourself, you should be the one who is speaking.
I love that. I love that. I think that really is a wonderful note to end on. I will just do a little bit of the housekeeping for our next rounds. I just want to thank Lakshmi and Julia so much for coming, for sharing, for inspiring. I just feel very, very full from your comments and ready to get out there and continue to speak up about these issues. We will have our next rounds February 28th. We encourage you to please share your feedback in our post-round survey. And if you want to know more about previous rounds that we've had or request recordings, if you missed them, check us out on the website at DFSM. But I want to thank everyone for being here, and especially Julia and Lakshmi for all the work that you've done to keep our community safe. And I cannot wait for us to continue this conversation in different fora, and for us to come back together next month to continue our social medicine rounds. Thank you, everyone, and have a great night.